with substance abuse, with behavioral disorders that we see oftentimes in kids, ADHD, any of those things, they're kind of interchangeable at this point. And when we do see any people that do receive treatment for this, it's often from the general pediatrician or the general family practice provider. I think these numbers were also staggering. There's a lot of data out there right now about mental health in primary care, not just pediatrics, but family medicine as well. 13% of our school-age children and 10% of preschool-age children present to their pediatrician or their primary care person with concerns about their children. I would say in our clinic it's probably a much greater number than that. We probably have a little bit more of a biased sample, but a huge number actually have concerns earlier on and may go undiagnosed. So we may not know what to do with them at that point, but they do present initially with that. And then out of all the visits that they're seeing right now, 70% of them have some kind of psychosocial basis, some kind of mental or behavioral health component to it. I don't know about you guys. I feel like my clinic is even more than 70% a lot of times, because they'll come in with sore throat, but then have something else on the side. So some portion of their visits have some kind of behavioral health component. And the highest utilizers of the healthcare services commonly have these untreated or unresolved behavioral health care needs. So when you think about that, you think about the ER frequent flyers or those that come to the clinic the most. They're often the ones with the biggest problems, the unresolved behavioral needs. And then you think about, also don't forget about somatization, where they have a headache or vague abdominal pain. Don't forget to think about behavioral needs or mental health needs in those people that we think is just outwardly physical problems. So we are seeing this service crisis right now. I think this plays into our admissions to the hospital right now as well, especially in rural areas. There's fewer mental health and medical services in general. There may not be hospitals open or a great number of clinics. Some areas don't even have pediatricians. So there's especially fewer mental health places for these people to go in these rural areas. And then oftentimes in rural areas, they do not perceive their need for treatment as much as in an urbanized area. So what do we consider rural when we're studying this, and where's our crisis lying? What is considered rural? Would anybody consider Washington County rural? Sullivan County, Unicoi? Yeah? You think so? I mean, I think it depends on where you came from. For me, this is a big city. So they're actually, the U.S. Department of Agriculture and the U.S. Census Bureau actually come up with what they call a rural-urban continuum code, and it goes from 1 to 9. 1 being the most metropolitan or most urban area, and 9 being the most rural area. They have those numbers. They change them, I think, every 3 or so years. To be a level 1, you have to have 1 million people. A level 2 is approximately 250,000 to 1 million, and a 3 is less than 250,000. And then if you get to a 9, which is the most rural area, then it's, it's less than 2,500 people. Where I grew up, we have less than 1,000 people, so we're obviously a 9. Washington County is actually a 3, so they consider it to be more of a metropolitan area. And Sullivan County is actually a 2. So I consider this more rural. A lot of people moving into this area consider it a little bit more rural, but by the U.S. Department of Agriculture, it's not as rural as we once thought. So technically, our services should be a little bit higher here, but we're still seeing very rural kind of culture here. A lot of times people interlapped rural with poverty, which is not always the case, right? But I wanted to bring in that approximately 20% of children in the U.S. right now live in poverty. And these are our guidelines here. When you think about this, if there's only one person in the family, guideline for that would be $11,000. I mean, it's staggering to me to think that we have large families, we have unique dynamics in families where they're multi-generations, where grandparents, great-grandparents are taking care of these kids. So when you think about that, there's huge numbers, and often there's not a lot of income with those families either. So to be in poverty, $40,000 for an 8-person family. I think it's staggering numbers. And when we think about kind of rural and poverty too, where is this most happening? Where's this most commonly happening in our area? So the South is obviously going to have the highest rates of poverty. You can see there. The Northeast and the Midwest kind of have less poverty, and then you get out, you think kind of the extremes of the two are going to have the most poverty in the United States. And then I like this graph because it shows the rural overlapping with poverty. And again, you can kind of see that the southeast is especially dense with kind of where what we were considered more rural, and then low poverty rates as well. And that's definitely affecting kind of the population that we're seeing in our clinics and around this area, whether it be Washington, Sullivan, Unicoi, any of those counties. So when we think about these numbers, again, getting back to the real core of this, what we're here for is the kids, right? So the percentage of children that have behavioral emotion problems lasting 3 months that are lying in poverty, again, those numbers, an 8-person family, less than $40,000, 16.4% of children not in poverty is a little bit less at 12.7, still pretty significant numbers. But then you look at those that are treated for their behavioral health problems, only 2.5% of children in poverty are being treated, whereas if they're not in poverty, they're being treated more, but they have less numbers. So the needs of rural areas are not being met at this point. We know that studies have shown, and again, there's more studies out based upon adults, but people in rural areas tend not to seek care as much, right? So people in rural areas, they don't have the health centers, which we've already discussed. They may not have the mental health facilities, but we also know that they also have increase of cardiovascular disease. They're coming in with heart attacks, strokes, those kind of things. They have more accidents, more traumas. They have a higher cancer risk, arthritis, diabetes, obesity, and smoking. And I think a lot of that is actually, when we think about not only our patient population, but also the parents and grandparents, we're seeing these things in our rural areas. If we think about strictly just the youth and kind of cut out the adults for just a minute, rural youth now these are compared to the urban population, experience decreased interpersonal conflict. They have fewer externalizing behaviors, so they have less aggressive and disruptive behaviors, which I thought was interesting. I don't know how they got that data exactly. I don't know if they asked for input of their daily feelings or what. Youth in rural areas do have increased loneliness. They have smaller peer groups. It may be because there's not as many people, but they're more family-oriented and often have more of a faith-based family core. When we think about their ability to seek help, so getting especially mental health services, youth rarely seek out help on their own, right? We have lots of youth that come in, they're bottling it up, and it eventually blows at the end, and that's what brings them into us, or why they come in for mental evals. But they rarely seek professional help, even when they're at their lowest point. It takes something drastic for them to actually seek help. And rural youth are much less likely to seek professional help compared to urban youth. It may be that there's more knowledge surrounding urban youth. They may have more resources. They may have more education that kind of lead them to seeking professional help. But we do know that rural health, they do not seek it as much. And if they do, they're most likely to seek it from friends and family, somebody they have a trusted relationship with, whether it be a coach of their football team or somebody at their church, the school counselor, somebody like that. That's who they're going to for help, rather than somebody with professional experience and somebody that's trained to do so. Who are the most likely people to do this? So females are 2 to 1 actually more likely to seek help than a male. I don't know if that's because we're more in tune with their feelings or we're more emotional in general, but we are more likely to seek help. The extremes, either very low or very high SCS, are more likely to seek help, whereas the kind of the middle core are not. If they have more knowledge or understanding of mental health issues, they're obviously more likely to seek help, which I think makes sense. If they're kind of aware of their feelings, or if somebody around them has sought out help, they're more likely to do so as well. They're also more aware, if they're more aware of resources, they will go seek help. If they feel validated in their feelings, if they feel like they're able to speak out and not be judged by that, they'll be more likely to seek help from providers. And if they have that trust relationship like we talked about, whether it be their coach, their pastor, their school principal, whoever it be, if they trust that person, they're more likely to open up and kind of get the help that they're needed, rather than bottling up and waiting till the end. Compared to the urban youth, rural residents, again, have this more negative attitude towards mental health and mental services. They may not be as educated, like I said before, but they have this more negative attitude and therefore don't want to seek the help. And there's definitely an increased stigma in rural areas. I think we see that here. We'll talk about that a little bit later, but if somebody's considered crazy or if they have bipolar disorder, that's often looked down upon rather than somebody able to seek help. They won't be as likely to go get and talk to somebody, go get the help that they need. Children as young as 5 years old are found to endorse more negative attitudes for mental illness. And actually, I think this is funny. They polled third graders, and they tend to think that a person with mental illness is worse than somebody else. So if they've given an option, they're always going to think that the person that is sick mentally or has a behavioral problem is worse than somebody else. And that goes along with the stigma in a rural community. They don't see that as much in an urban area. And those with mental illness are viewed as less attractive, and they don't want to be with them. They don't want to associate them. It's not somebody that's in their friend group as commonly as somebody, quote, normal. The media is obviously playing a huge role in this. There are hundreds of movies and books and websites, YouTube, that out there, they see somebody that they think is mentally ill, PTSD, whatever it is. There's this depiction in the media, and so that there's automatically a thought that these people have this violent history or they're going to be out of control and they can't be monitored, or you want to distance yourself from them. Again, the males are less likely to seek help. They obviously have these more negative attitudes. I don't know if females, again, are more in touch with their feelings, but males just have this more negative attitude towards seeking help in mental illness. So what are the problems that we're seeing with people that want to actually seek help? Is it that we don't recognize the need for treatment? They're seeing that urban youth, again, are more in tune with their feelings, whether it be their education or somebody that they know that has sought help. But rural residents do not recognize their need for treatment, so they're less likely to seek it. In rural population, and I know from growing up in a very, very rural area that there's this belief that I can change it, I can do it on my own, I shouldn't have to burden anybody else with my feelings, I'm going to internalize it and deal with it myself. And there's a strong faith base, again, in a rural area, so oftentimes I've heard, and again, faith, there's nothing wrong with having faith, but a lot of times they'll come in thinking, I'll pray about it and I'll deal with it myself and things will automatically get better, and they're less likely to seek help if they have those thoughts. Other variables to receiving treatment, if they don't have a facility that's close by, they're having to be transported to these facilities, and oftentimes they're hour to 2 hours away, if even that close. And even in our clinic, just to get to a well child check or a sick visit, we're hearing that they don't have the transportation to get there. They can't get down off the mountain. There's snow. How are we going to get there? Also in these rural areas, and I think we see this in every field, much less in mental health, if you're in a rural area, people go away, right? It's hard to keep people in these areas. There has to be some either connection to the area, whether they're from there, they have family there, some desire to stay in an area. Otherwise, they're going to go out and kind of go to these more urban areas because that's more attractive. And the pay is better. They are more likely to be reimbursed in these bigger centers. Unemployment obviously causes it. Lack of insurance, which we're seeing that all the time. Insurance won't cover screeners. Insurance won't cover their therapies. And therapies are lasting. I mean, sometimes, depending upon what mental health diagnosis you have, therapies can take weeks, months, or years before they're considered okay and don't have to have it anymore. Sometimes it's a lifelong treatment. So how do we get around all these barriers and kind of this stigma of mental health or behavioral health in our clinics or in the hospital? So they talk a lot about just developing a cultural awareness. So knowing your population, knowing what their family basis is, knowing where they're coming from, what their religion is, kind of meeting them on a medium or a middle ground. Is their pride kind of blocking their way? Are they have more autonomy and don't want to seek that help? SES, not going to be a lot to change that, but just knowing that, the very low or the very high SES are most likely to seek help. Knowing where these patients are coming from, meeting them on their middle ground and kind of giving them the pros and cons of doing this will often help. Knowing that geographic isolation is a big deal. If they're miles and miles or hundreds of miles away from this, it's going to be hard for them to do it, and they're going to be more likely to seek the people around them. Again, some other cultural awareness ideas, the modesty. If they're independent or too self-reliant, are they just doing this because they're agreeing to it based upon what somebody else says that they should do? So meeting your patients, knowing where they're coming from, understanding their culture is going to be huge, especially in these rural areas. So you need to normalize the help-seeking process for them. Again, I think Dr. Allman did a great job yesterday kind of giving the pros and cons, saying, you know, it may be a lifelong thing, but these are the benefits of having a child like this. This is the great things that they can do. These are the things that they can't do. Make it something that they can understand. And dispelling the myths, not everybody's violent. Not everybody's going to hurt you. Not everybody's crazy. There is a wide range of behavioral health disorders, and you can't just put one umbrella term to meet all these people. And then if you can engage the entire family, that's often a great way to meet it, because the rural areas do have this huge family core. So if you can get everybody to come, whether it be family therapies or fun games or something that they can do at home to work on whatever issue that they have, that often helps. But this can be complicated. Again, we're seeing great-grandparents and grandparents often treating, and then we don't know where dad is or we don't know where mom is, and so that often can be very difficult. So why primary care? Did I skip a slide? What is the big push right now with primary care? We see that 70% of mental health problems are showing up in our general clinic. So that's a big issue right there in itself. But we're the people that see these patients all the time. So they're coming in when you're first born. How many visits do you have? You have a ton of visits. Your newborn visit, if you have a weight problem, then you're 2 months, 4 months, and on. And then you should be seeing every yearly, right? And oftentimes there's multiple sick visits in between. So we're able to kind of build this rapport with patients, and there's a building trust relationship, which goes back to what we talked about earlier, that building trust is going to be essential with these patients. And then recognizing early that there may be a problem, and then getting a head start on the treatment, whether knowing that you want to treat it in your clinic or you want to refer out, is going to be crucial. But you have that opportunity, because if you're keeping in touch with your patients and you have good rapport with them, then you're able to kind of catch these things early. And then we do things already in our clinic, the anticipatory guidance. We have timely interventions and we promote these healthy, active lifestyles. So that makes it unique of why we are playing such a huge role in this. And this aligns with all these talks I know we had, especially at the beginning of the year. The new interns are going to get this medical home, this idea of medical home. So it's going to start with us being the ones that kind of manage these treatments. So what can we do as pediatricians or as family medicine doctors? So the AAP recommends that we have this basic comfort level with ADHD, and I hesitated to put ADHD in here as a behavioral mental health thing, because it's not often seen like that. But I did include it because the AAP does say that we should have this comfort level with treating and recognizing ADHD, anxiety, depression, and behavioral issues. So I think we more often think about this in our adolescent patients, but we definitely can see these in our younger patients as well, and they recommend that we know what to do once we see these, kind of what to look for in these patients. A study looked at how a primary care physician in general, kind of their comfort level with behavioral health, and only 13% of primary care physicians felt comfortable with a behavioral health issue. Pediatricians or family medicine docs were more likely to refer out if they could. If they couldn't refer out, they were more likely to prescribe medications rather than either one, waiting and seeing how the patient did, or doing their own kind of management of their own therapy. So we're more likely to kind of push it to somebody else or give a pill rather than seeing what else we can do for these patients. So this is from Johns Hopkins in conjunction with the AAP. They came up with 8 drugs that they thought we should feel comfortable with when treating anxiety or depression. I don't actually get into these drugs a ton because this talk is not just about medications. We're talking just behavioral health as a whole. But I wanted to bring this up, that there are drugs out there that they think that we should feel comfortable with. And note that there is no anxiety. We list SSRIs for treatment of anxiety, but there's no FDA-approved drug for anxiety in children. We see it a lot. We use it a lot as an off-label, but there's no FDA label for that currently. And I don't think in our regular side of our clinic, how many of us have prescribed any of these? Now, Dr. Chastain does, but I don't think any of us have prescribed these on our regular clinic side. You can correct me if I'm wrong. So what do? If we don't feel comfortable giving medicine, we don't want to start with medicine, what are some things that we can do before then? So pediatric screeners, which we do a great job of in our clinic. But this is, again, the idea of bringing these screeners in because it's a validated, reliable measure that we can use for these None of the screeners are meant to actually diagnose any disorder at all. They're just supposed to say, do we have a problem somewhere? What are parents thinking? What are we seeing when we observe these children? So any of these screeners that I bring up, don't think that this is going to be an end-all, be-all, and if they have an abnormal score in their MCHAT, they automatically have autism. It's just supposed to be a way for us to detect earlier and kind of keep an eye on certain problems. So the EPSDT is something that Medicaid does. It's kind of it's considered a service that they do. So it's an acronym. So they're saying if they assessing and identifying problems early, checking children's health at periodic age-appropriate levels, so at your well child checks. And then the S is providing the S is providing physical, mental, developmental, dental, hearing, vision, and other screening tests to detect early problems. The diagnosis, performing diagnostic tests to follow up when a child is deemed to be at risk. If we see something abnormal, follow up on those patients, don't just let it slide. And then the T is control or correct or reduce health problems that are found. And this is something that Medicaid is pushing for every child under the age of 21, kind of the service to kind of go through this in your mind. It's not actual screening, nothing that you write down on paper for these kids. We do this in our clinic, and I bring this up, it's given to mothers, of course, but I bring this up because if a mother's mental health is not stable, then she's not able to take care of her child. If there's anxiety or other problems in the home, that can often be pushed to the child, and then we're seeing that children that are around high-stress environments are often seeing mental or behavioral problems within themselves. And so there's a huge coping problem in the household if it starts with a parent that has a mental disorder. So this is something that we're doing from birth to 6 months. It's just a 10-question scale assessing the depression and anxiety. They recommend that scores over 13 should be further assessed, so whether or not it's seeking back with their OBGYN, if you're talking about it themselves as a pediatrician, if you're giving them handouts, or if you're referring them to behavioral health, whether that be a phone call follow-up or having them seen in clinic. So we worry about this because postpartum depression is so common, and it's the most common mental disorder with childbearing, right? So it is something that we should be following up on. It's a service to our children through their mother. So this is just a copy of the Edinburgh depression test right there. So pay special attention to number 10 on this because that asks if there are any feelings of self-harm, and that automatically requires something else to be done, an immediate intervention at that point. But it asks if you're able to enjoy yourself the same way as you were before. Do you blame yourself more? Do you find things to be funny? Are you more anxious or more worried than normal? Do you feel more scared? Are you able to cope as well? Or your overall feelings of sadness? Kind of where you are after this big life event, how are you coping and how are you able to take care of your child? The infant development inventory is not something that we do. This is more looking at kind of global functioning of a child, the social, self-help, gross, fine motor. We ask a lot of these questions, but this is where the parents fill it out and kind of give us an idea of what they're thinking. You can often observe these behaviors or concerns while they're in clinic, but it's from birth to 21 years old. And it doesn't exactly hit on mental health disorder, but comorbidities often overlap between a developmental delay or a problem in one area will often overlap with whether it be a behavioral problem later on. So this kind of is a one screening tool so that you can monitor and say, this kid may have some delays, and what do I need to look for in the future? It's how the baby's functioning. So this is a copy. So what you do is you kind of mark across the child's age, and then the parent is able to put a check mark as something that the child has done. They'll put a B if it's something the child is beginning to do. And you can see the different categories. Again, these are developmental milestones, which Dr. J just went through. But if they're meeting where they're supposed to be, if there's more checks above or below the line, kind of where they are developmentally. If they're 2 standard deviations or 70% off, then that's a reason to refer. If they have a lot of areas that the child hasn't met yet, then that's another way to say, I need to watch this kid. They may have one area that needs extra help or extra attention to, whether we need to refer to TEIS or some other source for further care. You can have a lot of these check marks, but again, this is a parent bias, so always use your clinical judgment, what you see when the patient's in the room. The child development review is the same thing as the infant inventory. It just goes from 18 months to 5 years. And again, it's the patient or the parent's observations of the child. It sees their developmental milestones. Again, the same kind of scale as the other one, but it just goes up to 5 years of age. So you're getting kind of more into the school ages there, kind of when they're preparing to go to school. Where are they functioning? Are they prepared to go to school? Do we have behavioral issues? Are they meeting everything that they need to progress appropriately in life? And these are often done at your well-child checks. The MCHAT, I did not know when I put this in there that Dr. Allman was going to give a great talk yesterday about the MCHAT. We do this in our clinic, ages 16 to 30 months. Again, it's parent report. Again, this is a screener. Parents will often put something because they don't understand part of the question, so it's always okay to go back through these screeners and clarify with parents what they think, why they didn't mark a certain answer. I'll often get, yeah, he seems sensitive to loud noises. Does that really mean that we're looking at something along the autism spectrum line, or is it just that you beating and banging around the house and the kid wants to plug his ears? Special areas are does the child look at you, or is there any abnormal hand flapping, or the loud noises, which seem to get cued the most because parents don't understand those questions. And so, it doesn't diagnose autism. Those need to be referred out to a specialist that is doing more thorough work, often 3 to 4 visits of testing and monitoring the child. But if something comes up and you can't clarify with the patient and the parent is insistent upon that their child is doing something abnormal, then monitor that kid. Send them where they need to be. Watch them in your clinic and see what you think about the child. Are they displaying any abnormal behaviors that you're concerned about? And I think, we usually are told autism diagnosed around the age of 3, but Dr. Allman mentioned yesterday, she's seen kids 18 months, 2 years of age that are now being diagnosed. So paying close attention when we first start handing the MCHAT out can get a head start on what we need to do later. If there is high risk of autism, or we're seeing those kind of characteristics, then getting interventions for these child will definitely help them later in life. They have better outcomes. Keep in mind, too, that the MCHAT has a high false positive rate. So the goal is to maximize sensitivity and detect as many cases as possible again, but there is a high false positive rate for many reasons. The Pediatric Syndrome Checklist is a great screener for behavioral concerns. We don't do it at our clinic, but a lot of pediatricians do use this, age 16 to 18. Just 3 columns, never, sometimes, and often. The scores vary depending upon the ages. A score greater than 27 and ages 6 to 18 will indicate further assessment, 24 for the younger kids. You can look for high scores, or if there's an area where you see a pattern that they're putting more problems in, that's a reason to refer. It'll take a closer look at this child. So this is the PSC. Range of scores can range from 0 to 70. Sorry, I thought there was a question. You delay this for there's different questions, or you have to rephrase questions for elementary school children, but how are they doing overall? What are their behaviors like? Are they irritable and angry? Are they feeling hopeless? Are they getting in lots of fights? Have they had great grades and all of a sudden their grades are dropping? Are they having difficulty sleeping? Are they listening to rules? Are they able to show their feelings, which I think is a unique question. I don't know how many kids younger are going to be able to explain their emotions, but it's starting to tap into those things. And I think this is a great screener because not only is it giving you a clue to what the parents are seeing, you can observe them, but it also lets the parents look at these and say, maybe I need to take a closer look when I get home. Are we doing this? Do I have any concerns in any of these areas? This is the PHQ for adolescents. It's another screener that's great. This one looks more at the depressive disorders in teenagers, though, ages 11 to 17. Again, it's by patient report. It's not looking at that moment in time, but a past week. So this has to be followed multiple times if you see something abnormal. So you're not going to just treat or diagnose depression based upon this, but you're going to mark this screener, ask them the appropriate follow-up questions. And a lot of it is the depressive things like the SIGI CAPS kind of questions. So you can see that if they get a 20 to 27, that is a severe problem, and follow up more closely with those. Have a conversation with anybody they'll allow you to, whether it be a family, somebody that they trust to discuss this with. What do we need to do to keep these kids from cutting, from hurting themselves, from coming in the hospital, for mental evaluations, keeping them out of Woodridge? What do we need to do? So this is the the questionnaire there. Again, it follows the CE-CAPS kind of, are you feeling down, depressed, irritable, or hopeless? Do you feel that you're talking or moving more slowly than normal? Do you have trouble concentrating at school or at home? Are you feeling bad about yourself? So just very basic questions that a lot of pediatricians probably ask, but this is a good number in front of you, a good visual cue for the patient and for you, and then you can keep track of it across the boards. Where were we the last visit? Where are we now? Do we need to follow up more closely than what we were? The CRAFT study is for substance abuse. Again, when I listed the problems that the AAP states that we should feel comfortable when treating mental illness, substance abuse was on there. I'm not sure how often we do this, where exactly to go with this, but this is a screener. If we're uncomfortable asking these questions, if we're not sure what age or where they are in their stage of life, this is non-biased. You give it to every kid between the ages of 11 and 21 and let them kind of fill it out themselves. And so from there, you can kind of target your own questions. Any answer on this should be flagged. So if they put down any of these things, you should take a closer look. These are kind of like the cage questions that we typically ask of adults. This is the screener right there. So the CRAFT stands for, have you ever ridden in a car driven by someone, including yourself, that was high or had been using alcohol or drugs? The R is, do you ever use alcohol or drugs to relax, to feel better about yourself, or to fit in? A, do you ever use alcohol or drugs while you're by yourself? So the A is alone. F, do you ever forget things while using drugs or alcohol? So if kids will say that they blacked out, is that something that they're doing when they have alcohol or drugs? Is that something that they're doing often? Do your friends ever tell you that you should cut down on drinking or drug use? And then the T is, have you ever gotten in trouble while you're using alcohol or drugs? So this is a great conversation, much like the CAGE questionnaire, to get a conversation started between you and those teenagers, because we are seeing these kids and it's extreme. They're coming in with overdoses. They're depressed and they feel like the only way out is to take a bunch of pills or to drink. And then Jen did a talk last week or 2 weeks ago about the problems that we're seeing with these new drugs. So are they getting involved with this? Do they feel like they have to do that to cope with whatever's going on with their life? Is there some kind of home situation that they're having to cope with and they feel like this is their only way to do so? Are they feeling down, or do they just feel like they have to do this in order to fit in with their peers? So outside of the screeners, what other tools do we have around to kind of help with this? Where do we start? If we have never had experience with this, we're not sure how to bring up these questions. The AAP has a mental health initiative, which is awesome. It has great, what they call tips for pediatricians. There's a bunch of online resources. There's handouts. There's books that you can buy or books that are online. And then they also have listed the AAP policy on mental health, which gets updated all the time. And that's where a lot of the guidelines of what drugs they think you should be prescribing, what things should we feel comfortable with handling, because we are the ones that get the first look at these kids. What should we feel comfortable in doing? And then the guide to the psychopharmacology, which I listed earlier, which is in conjunction with Johns Hopkins. There's an AAP mental health toolkit, and I believe Dr. J has this in clinic that you can look at. It's videos and things that you can go to kind of help you with ADHD, substance abuse, and depression. In the state of Tennessee, we have the BHIP, which is a fantastic resource. It's free. You can do it for CME credit. There's guidance videos on there. There's instructive videos. It goes through depression, and then it goes through the treatment and things that you should look for depression. Some of them are shorter, some of them are longer, but it's great educational tools. So if you just Google like Tennessee AAP and then the BHIP, that comes up. And then again, all the pediatric screeners that I previously listed. A lot of them are free online. If you don't want to do the screeners, it'll give you guides to questions that you should be asking your population in order to kind of get a handle on the mental health or behavioral problems that you're seeing, so that we can treat them earlier and help these kids live better, longer lives. So this is by a pediatrician in Tennessee. She's actually coming, I think, next week or the week after to talk to you guys. Michelle Viscus, I think. She says, as convenient care clinics see more and more of the simple problems, so the acute care clinics we are seeing in our offices, the population of patients we see is becoming increasingly more complicated, and many of these children have undiagnosed behavioral health issues. And I thought that was a great way to clarify it. She's going to go into more of a talk. I think the 22nd she'll be here to actually go through more of this with you guys. But we're seeing these children, they're going undiagnosed and they're having more complications later in life. So as pediatricians or general health, we should get a handle on it early, be looking for these things in our clinic, and be talking to our patients to see what we can do for them. Any questions? had a request for pictures. Yeah, Dr. Woodhead.
Excellent talk.
Thank you.
Two questions. One, genetically, what are the genetics and certain mental institutional schizophrenia? Two, do you have any statistics about other Western countries when it comes to behavioral and mental illnesses?
So if they're more likely in other countries to kind of seek help?
I think maybe, or maybe we have more old patients that have.
Yeah, I don't know the exact numbers. I think there's more of a stigma in the United States about mental health disorders. I don't know if the media is playing into it again, if we have more of a rural population. But I think in European countries especially, they're more open to their feelings and more free, expressive than we are in the United States. So I'd say that they're more likely to seek help. I don't know the exact numbers. And I don't know that there's ever been a true, unless there's a diagnosis of some kind of genetic disorder that has a comorbidity with autism or whatever, that there's exact numbers. But we know there's a lot of genetic predisposition or familial traits between schizophrenia, bipolar, depression, those kinds of things. So oftentimes you're seeing if it's a member of the family, then there's a higher risk of a child having it, definitely. I don't know that they've ever found an exact deletion or translocation that is cued into that. There's lots of research on it. But there's definitely a genetic predisposition. If one member of the family has it, then likelihood of a child having it, which is why we ask the great family history questions, right? Who in the family has had these problems? Anybody else? Yeah, Dr. J. Right, right. Yes. Right. Right. Yes, yeah, we do a modified. I think, and our clinic is very unique. We do have the behavioral health right there. And actually, part of the thing that the AAP brings up in their policy statement is teaching our residents, keeping mental health a high priority in our resident training so that we can go out. And I think our clinic does an excellent job because we have the resources right there. So we're doing research on it. We're using these screeners. We do a modified screener, but I put the whole one up because it is an option. And then we do have the option of having somebody right there, whereas a lot of clinics don't have anybody right in their office to see immediately that day. Don't forget that mental health people can be psychologists, psychiatrists, can be licensed social workers. So there's a lot of different variability with those. And you may have somebody close by that can help with that before they go in for further actual diagnostic testing. Yes.
I just had a comment more than a question, but as you mentioned, we have an integrated behavioral health care system in our practice and a few other practices in the area too. But I actually was sent a survey by the Tennessee AAP that I filled out last night asking about integrated behavioral health services in pediatric clinics. So I'm wondering if there's going to be sort of a push to more open incentives in doing that, because I found that to be really helpful, because we know when we refer, a lot of people don't.
Yeah, I would be terrified if I were going to practice without that. I'm biased. My husband does this for a living, right? He does integrated behavioral health. But I think it's the way to do it. Not only does it free up some of our time, but they're getting, there's people out there that are trained to deal with this all the time. That's what they do. So it can take away, educate us. It can help us with the flow of our clinic, but then they're getting the help that they need by actual people rather than us saying, we don't know what to do with you. Let's throw something at you. Let's wait and see what kind of happens. I hope that's the way the medicine's going. Anything else? Some references. And then that is it for the class of 2016. We're done.